So now we've got basically 3 trials that have given us some answers, some haven't. We've got 189, we've got Empower 150, the 4 drug, and then we've got dual checkpoint blockade for high TMB that didn't shake out in terms of overall survival. So let me ask before I ask you, Sam, do you do TMB at all on your patients? Are you being asked to do tumor mutation burden in non-small cell lung cancer?
So we do get asked about TMB and to do TMB in some patients. I think one of the challenges right now for TMB is there's not consensus about how it should be performed. And so within the diagnostic community, you certainly need to do next generation sequencing. There's a question about how many megabases you have to sequence to actually get an adequate power to the value you come back with. Also, the question, do you have to compare it to normal? Do you have to have a normal match to get an accurate TMB? So there's no standard out there right now for how TMB is done. I think that's muddied the waters in terms of being able to accurately determine how TMB is useful in patient care. So we get it. I'll do it if it's required, but in general, I think you have to be careful about just because you have a number, knowing how good the data is behind that number.
Yeah, good point. Are you using dual checkpoint blockades in your non-small cell lung cancer? Are you using Empower 150? Any of these regimens made their way into your clinic routinely?
So I think, Ben, you so nicely highlighted the treatment algorithm and the options that we have for a patient presented in this case. And I think the main goal is to find which is the perfect patient for each treatment option. So perhaps someone that is extremely symptomatic and maybe poorly differentiated, as we were discussing before, may be a good candidate for the quad. As opposed to someone that you have the luxury of having TMB on, and perhaps it is like this patient, TMB of 18 or very high tumor mutation burden, over 10 megabase pairs. This might be someone, if you have this information up front, it may be worth a discussion regarding upfront Nivo/Ipi versus Keynote 189 versus the quad.
Yeah, I think we're still waiting for the Nivo/Ipi data to be a little bit more formalized and mature to make those decisions. We're not routinely, Hopkins does a TMB on all our patients. It drives me crazy because it does sop up a lot of tissue, but we are an immunotherapy institution and we do TMB, and I think there may be some value to it in the future, but in routine clinical care, I don't think we're there yet. I'm glad, I'm giving it a hard time. I'm glad we're doing it because I think it can be used in the future. So this has been a wonderful discussion. Thanks everyone for their insight and their ability to kind of layer in their unique perspective to these cases. Dr. Jain, thank you. Dr. Yarmus, Dr. Koren, and Dr. Walker, and Dr. Prishigal. You've all done a wonderful job layering insights in these thoughtful case presentations and this lively, informative discussion. To our viewing audience, thank you for joining us for this Target Oncology Virtual Tumor Board presentation. We hope today's discussion was a valuable use of your time and that you acquired some practiced knowledge that you can take back to your clinic today.